I would, of course. Wonderful. The meeting is being recorded, so that confirms that we are beginning our last Health Research Institute seminar for this calendar year. So that is, it has been quite the year, as we all know, and I do want to just acknowledge as we are beginning this session today, not only that that we're acknowledging the lands and communities that enable us to gather and to contribute from UNBC and the health research community. It's always important to acknowledge the fact that we're privileged to live and work and play and learn on Klatle territory. Just, I think it feels like a nice thing to be able to say that this is also an international Health Research Institute seminar, because I am actually calling in from the traditional territories of Ngāi Tahu in Aotearoa, New Zealand. As some of you are aware, I'm back in New Zealand for family reasons. So this is already a world famous seminar series. We'll go to the next slide, Bree. So most of you know me. It's really lovely to see faces there. My name is Margot Parks, and I'm one of the team that puts together these Health Research Institute seminars. We've got a whole range of schools and contributors that are part of this, including the slides that are zipping past your face at great speed here. I'm in the School of Health Sciences, but we also are hearing from and designing with a number of different contributing departments and linkages across campus, the School of Nursing and Social Work and the NMP, Psychology. We do get funding support from Sun Life Financial. We'll go to the next slide, Bree. So we are a result of the foundational work by the Health Research Institute, and we wouldn't be able to put on the series without the support of Bree, and who's always happy to hear from you if you've got suggestions, both about the Health Research Institute in general, but also about the website, and about that's a place where you can always find past talks and future talks. I think there's a wonderful archive of talks, and we're all aware that December's a busy time and a tricky time to gather together with so much going on at the end of semester. So people can always direct students and colleagues to hear these great presentations. So we'll just go to the next slide, Bree. And so the speaker today, who I'll introduce very shortly, is Tammy Klassen-Ross. But I have been asked on behalf of the Health Research Institute to also make an announcement today, which I understand is coming out in multiple formats and maybe popping into inboxes today, which is that we would not have the series or the Health Research Institute in its current form if it wasn't for the other smiling face on the screen right now, the fabulous Rachel Wells. And we're really wanting to acknowledge Rachel today, given that she's been her amazing skill set and contributions to research at UNBC has been recognised elsewhere, and Rachel is moving to take up a position with Caris County Family Services in the new year. So this will be, I think, our last seminar with Rachel in her current role as manager of the Health Research Institute. And so it really is impossible to imagine right now how the Health Research Institute is going to be the same with Rachel moving on. But I think it is actually a real tribute to the style in which she works that we've really benefited from the way that Rachel has built health research capacity with the support of the HRI Leadership Council, but really operationally driven by Rachel's vision of how to create in complex environments, really supportive environments for researchers to imagine how they can make connections, how they can get the research assistance they need, how they can be fueled by past precedents of knowledge and research on campus. Rachel has an incredible suite of insights about our university and the broader health research community. So it is a relief that she is only moving to another institution, and I know how much that institution will benefit. But on behalf of the HRI, Martha McLeod's not with us today, but asked me to send her, in particular, her appreciation to Rachel. I know the past co-chairs, Jeff Payne and Henry Harder, have also really valued Rachel's contributions. And on behalf of the wider health research community, Rachel, we're going to miss you in ways that you can't possibly imagine. You've been such an asset, certainly to me as a health researcher as we've been going, but we look forward to working with you in your new role. And thank you for all the work you've done to put us in such a good place.
Thank you, Margot, for the kind words, and to all the other kind words that are filling up my chat box on my phone at the moment. I'll miss you all. It's been a pleasure to work with everybody, and hopefully I will get to continue to maintain several relationships in my new role at Karisakani as the Director of Innovation and Quality.
So, such is life in our health research community in Northern BC, that there are people that move across and connect with different organisations, and our speaker today really exemplifies that. It's really a pleasure to introduce my colleague and fellow School of Health Sciences faculty member, Tammy Klassen-Ross. Tammy's an incredibly valued part of our faculty. She's very active in terms of student success and in terms of progressing across our school various elements, whether it's a disability management program or her contributions to the various committees and to her own style of research, which is we're really looking forward to hearing about today. Tammy brings a really impressive, I think, background of partnership across multiple organisations in the health research community in Northern BC, and those do span across Karisakani Family Services, through to a whole realm of other contexts. So it's really a great pleasure, Tammy, to introduce you today. I want to say thank you even in advance of your presentation for being such a great colleague, and we're really looking forward to this opportunity to hear and give you the stage to share your contributions. I think that's all of the slides now, and we're ready to that's my slides done, Bree. Yeah, great. And so we're ready to hand over to Tammy.
All right. Thank you for such kind words, Margot. It's a pleasure for me to be here today. Rachel, congratulations. I think you're going to do wonderful things over at CSFS, and I wish you all the best on your new path there. So I'm going to try to share my slides. This is where we go, please work. Watch, we're going to have technical difficulties. Let's see here. Hold on.
The world of Zoom that we're also familiar with. So we use this as a moment to breathe and to trial a few things. Do we have another option for you, Bree? Do we have all of the permissions all set up at our end?
On your end, yes.
Yep.
You should be able to share, but if you are having difficulties, if you can send it to me, Tammy, I can share it on my end as well.
Yeah, let's see here. Let me just see if I can open it again.
And as we're doing that, Tammy, figuring the technical pieces, as most of you are aware, we do have the HRI series will take a little break over the next month, but we will be back, and we've got a really exciting lineup next year as well, including one of the things we enjoy is having profiling honours students and their research projects at the end of the spring. And we really like to line people up in advance and know of people that are interested and willing to contribute to the series, because we do sometimes have clashes or people needing to change plans at the last minute. And so it's great to know of other colleagues that are interested. How are you doing there, Tammy?
Good. I am just going to send it to Bree. Sorry, guys. My computer has decided that it wants to be difficult. There you go, Bree.
Okay. And so while we're waiting, do you want to kick off with a couple of introductory things while we bring up your slides, Tammy? I could keep rambling on forever, as you know, but
you could tell us how warm it is down there if you really wanted, because I'm sure
it's not. It's really cold and rainy and grey today, so I'm say that.
Okay.
Yeah. But I can say greetings from tomorrow, and tomorrow is a good day. So,
okay.
Yeah,
that's good to
over
know.
to you, Tammy.
All right, so yeah, I'll just do a little bit of an intro. So most of you who have heard me speak before and who've read the bio that came out, you might be like, well, why isn't this talk about pain? Because that's where I originally got my start, was in pain research. And in fact, I still do some pain research. But this opportunity came along to look at how we can, potentially recruit and retain rural physicians. And for me, that's actually really quite important, having not only grown up in a rural community, which I'll talk about in a few minutes. Hopefully my slides come through. Oh, look, there we are. There we go. Wonderful. Thank you, Bree. Yay. Okay. So I'll talk a little bit about how sort of this all interconnects with what I do. So the title of my presentation is actually Predicting Who Will Become a Rural Physician. Is it possible? Can we actually do this? Now, before I get started, I do want to mention two people who are pretty important to this research and what we're doing. First is Dr. Paul Winwood of NMP UBC Medicine, as well as Dr. Jeff Payne. Jeff is actually one of the people who started this project or this survey years and years and years ago. So I always like to make special mention of those two because they're very important to this research. So Bree, next slide, please. There we go. I do have a disclaimer. As you all know, med school is obviously very, very competitive. And as such, the questionnaire or the survey that I'm going to be talking about is an integral part of that admission criteria for UBC medicine. So I will not be discussing specific questions on the survey, just so that no one gets a leg up on the competition, so to speak, but I will be giving an overview of the results that we do have thus far. So just in case if anybody asks me any specific questions, I'm gonna say no right away. So I thought I'd throw that up there so everybody knew. Okay, next slide, please. All right, so, and you're going, oh my goodness, what in the world does a general store have to do with this story? So let me start back in the 1990s. Now I want you to picture a very small community, Anaheim Lake, BC, for those of you who know where Anaheim Lake is. It is a very small village about 4 hours west of Williams Lake. It is very rural. Now, why would I bring this up? Well, I actually spent a large part of my childhood there in the 90s. And we moved there because my dad was part of the logging industry, and that's where we were, and he was working for a company. Now, living in this community, it was very, as I said, very, very small. And there wasn't a lot of medical access, which is really interesting. They did have a medical clinic, so a medical station, a nursing station as we called it back then. And it was staffed by wonderful nurses who would come in on a rotating basis. Now, the only problem is the doctor would only come in once a week. So what would happen is you would have numerous people come in with many complaints throughout the week, and if the nurse couldn't handle it, then they would have to come back on Wednesday. So if you had a cold, if you had, let's say, for example, a sinus infection, ear infection, whatever it may be, you had to wait potentially a week before you got to see a physician. Now, you have to remember this is before the days, and I'm kind of dating myself a little bit, before we had telemedicine, telehealth, right, that we are so used to now. So this was a real concern. And if there was an emergency, so for example, a friend of mine broke his leg and he had to wait, and so this happened on a Friday, he had to wait till Wednesday for the doctor to come. He couldn't put any weight on it for fear that if it was a fracture, that he could do more damage to it, so he had to wait almost a week before he could see a physician. Major emergencies had to be flown to Bella Coola, which is 2 hours further down the mountain. And if any of you have traveled the road, you'll know what I mean by that. Hill can be quite scary. There was an incident actually with my own dad where he had a work accident and a grinder slipped and it actually cut his wrist. very, very serious injury. And thankfully that day, the head of the company that he worked for was there with his helicopter, and his pilot actually flew Dad down to Ballacoola to have surgery. This was a common thing where you had emergencies, you had to have people go down. And I love this picture of this storefront. And this is a store, if any of you have been to Anaheim, like this is the Christian store, which actually I found out recently may have closed down. And I don't know if you can see below the name of the store, but it says, if we don't have it, you don't need it. And that was the mentality. And I liken that to physicians, because if we don't understand the need for physicians in these rural areas, obviously we don't need them, right? If people aren't saying anything, then do we actually need them? So I really like the storefront, and it's something that we say in my family all the time of, you know, if we don't have it, well, obviously you don't need it that badly. But I'm gonna argue, no, we do need physicians in rural areas. If you wouldn't mind advancing the next slide, please. Thank you. So this was back in the 90s, you have to remember. So this was, you know, what are we going on, 30 years ago now? Ooh, I'm aging myself. But it's still a problem. Rural physician shortage is still a huge problem, not only in Canada, but in other areas of the world. So when you look at the research, if you even just type into Google rural physician shortage, you'll get articles from everywhere. Margot, you probably know of this issue in New Zealand. I know that there's a big problem in Australia, in the States, and any other areas where you have this rural propensity. And people will obviously live there. Bree, if you could advance the slide, I threw some stats up here. Hopefully they'll come up. So now obviously these numbers are going to change from year to year, but on average, there's 13 physicians, family physicians per 1,000 residents in northern BC. Now you can see where I have the cutoff here, and this is the north-south boundary. So the adage of beyond hope. So where hope is, everything below that, and what you can see there is that there's 25 physicians per 1,000 residents. Now, obviously, you know, there's more people down south, they're gonna need more physicians, but there's the sense that up north, we don't have enough physicians. And in fact, if you've been listening to the news lately, just dealing with the pandemic, there's actually been a rapid response team mobilized to, I believe, Fort St. James, because there isn't enough medical staff. Okay, so this is an ongoing problem that we have. Next slide, please. So what do we do about this? How do we address this? This has been something that universities have been looking at, medical schools have been looking at for quite a long time, trying to figure out what do we do. UBC has based their model off of a distributed model of undergraduate medical education. So you have UBC proper, where, you know, before COVID, all students would go down their first year for at least 4 months, 4 to 5 months, and then they would go to their different sites. And Prince George was fortunate enough to get one of these sites. And what we do here, and what the real push here is to teach rural medicine, right? Have people engage in rural medicine to see if they'll become rural physicians. But how do we know who's good for that program, right? And that's one of the biggest questions that we have is, who should come into the program? Because obviously, you know, the teaching, it's going to obviously meet standards, but we're going to have a little bit of a twist on it because we want to encourage these students to become rural physicians, because we need to fill these holes. We need to help those people that are in an emergency situation, you know, so you don't have to wait a week to go see a doctor, but you actually have somebody in your community, or at least close to your community, where you can get help right away. So UBC has, as I said, developed this distributed model based on previous models that have been used. And we have sites in, for example, on the island, in Kelowna. Okay, so there's a few other sites where this happens. But what's unique about UNBC is the fact that they have developed a survey to determine your rural propensity. Are you one who might become a rural physician? So can we go to the next slide, please? Okay, so how do we recruit to rural? Big, huge question, right? And this is one that people have been asking over and over again. And I've been working with the NMP on this question, I would say, for probably about 3 or 4 years now, just trying to determine, can we actually predict who will become a rural physician and who will not become a rural physician. Now, if you look at the research, and I've stated some here, and there's obviously a lot more out there, but normally what they say is that if you have experience in a rural setting, you will be more likely to become a rural physician. Now, there's a couple theories as to why this is. It could be something as simple as wanting to give back to your community, or understanding what it's like to live in that rural community. Now, some argue, as Roque and Wade do, that you need to live in that rural community all your life, and then you'll be more likely to become a rural physician. However, Wilson came back in 2009, and he actually said, you know what? Even if you only spend your elementary school years in a rural community, you will become a rural physician, or you're more likely to become a rural physician. So what that group of data is saying is that if you have any exposure to being rural, to understanding what it's like to live in a rural area, you are more likely to become a rural physician. Other researchers have come along and said, well, you need to have a certain type of personality as well. And Hughes is one who definitely says that there are certain personality types that will make you a better rural physician. Now, the problem with this is no one can agree on what those personality traits are. And I think this is very true in a lot of research that happens, is that you have so many different types of personalities, and people are different. They're going to draw on past experiences, they're going to draw on what they learned in school, they're going to draw on, you know, what they know. So is there an exact personality type? We don't know yet. And that's why I have a question mark there, because really research is still trying to figure that question out, and it's a big, huge question. So if anyone out there wants to do like a master's or a PhD in that, you'll probably have a lot of material that you could work on. As Margot's nodding her head going, yeah. Okay, next slide, please. So where does our survey come in? So what I'm going to talk about specifically is the Rural and Remote Sustainability Survey. Now, basically, what this survey does and what it was designed to do is to provide an objective measurement of an applicant's affinity for training in rural, remote, and or northern communities. And you'll understand in a minute why I said and or northern communities. This is a self-report screening tool. So this is part of the overall application package that is given to students who indicate that they would like to do their studies in Prince George, so in the Northern Medical Program. This screening tool asks questions about rural lived experiences. So on past research, drawing on that, going, okay, well, we know that past experiences can definitely influence our future decisions and what we do in the future. Another one is self-reliance and independence. So that is another, you know, kind of tapping a little bit into those personality traits, because if you think about somebody who lives in a rural area and is a physician in a rural area, they're going to have to, we think, and I say we think because we're not 100% sure on this, is are they able to draw on their own skills in certain situations? So if you have someone, for example, who comes into your clinic, you're the only doctor there, and they have a bleed in a femoral artery, what do? You have to get them out, you have to get them to emergency in, let's say, in a larger center like Prince George, but you're in the middle of a snowstorm. What do? You don't necessarily have the blood to give them a transfusion. How do you clamp that vein off? Okay, so these are some of the things that you have to be quick on your feet. So this is where self-reliance and independence come in, because you may be working on your own. Another thing that we ask them is rural-related activities. So one of the things we do know is that if you like living in a rural area, you're gonna probably already engage in those activities. So we can sort of tap into that as well. And then we have this other category called additional information, and I'm just gonna leave it at there just to have, you know, that little air of secrecy around it. Next slide, please. Okay, so with the data that I had, and this, you have to remember, this was developed, they'd been collecting this data, and it had been scored specifically for entrance into the program. So you would have to have a specific score, and that would give you a certain percentage on your overall application. So at the outset, this wasn't designed as a research survey. And that's very important, especially, and I know you guys have been talking a lot about different types of research and things like that. So I want to make that very clear that in the beginning, this was just data and it was used purely for admission purposes. Okay, but they were wondering, we have all this information, can we use it? Can this actually perhaps predict who will go into a rural setting? And can we indicate whether or not they will become family physicians or not? Because you have to remember, in medical school, you go through your 4 years, and then you kind of decide, what are you going to do, right? Are you going to become a family physician or a GP, or are you going to go more specialized and go into one of the specialties? So this is also an important question, because we know that in these rural areas, yes, obviously it'd be great if we could have a bunch of specialists out there, but let's get the physicians, the regular GPs out there first before we start worrying about specialists. And then I wanted to look at, is there a relationship between the RRSS and recruitment location? Okay, so what I mean by recruitment location, I mean, where do these students end up after medical school? When they're done their residency, where do they go? Do they stay in an urban area, or do they go back to that rural community like they wanted from the beginning? Next slide, please. Okay, so this is the specific data set that I used. Now, a lot of you are probably thinking, as soon as you see these dates, you're going to go, wait a second, Tammy, we're in 2020. Why did you only look at data from 2008 to 2012? There's a very good reason for this. Number one, as I said, this isn't research data. This is data from admissions. Secondly, we had to have time for these students to get through their residency and then get to a point where they were actually in a permanent practice. And for all of you physicians out there who are listening, you definitely know that when you get out of medical school, you may do a couple locums, but you don't necessarily settle where you want to be yet. So we wanted to take that into account. So that's why I chose this specific window. And you will be happy to note that I now have more recruitment data. So this will all be updated as I go along in future months. Okay, so how did I actually look at this? And this is sort of where the stats part of me comes in. So what I did is I actually broke the rural and remote sustainability survey into those subgroups that I talked about previously. Rural experience was one that I was really interested in, because that's what the literature had talked about. And it said, if you have rural experience, you're going to be more likely to actually be in a rural area after you're done medical school. I also was obviously interested in recruitment location. So where did they end up? Now, this is where the little hook comes in. What's rural? And you guys can put this in the chat as well, because I want to make this a little interactive. What is rural? When you hear the word rural, what is rural to you? And Bree, I'm assuming everybody can write in the chat, I hope, now that I put a question in. So I'll give everybody a few minutes. What is rural to you? Depends on who is footing the bill. Mal, I knew you would say something like that. I love it. Who else? What is rural? What do we consider rural? Okay, so Shannon, rural depends on the definition that you've selected to use. There can be many different ways to define it, definitely. Rural and small town. Okay, definition, I'm not sure that is, I can't see the full name. Anyone else? Population less than 12,000. No Starbucks. Oh, Andrea, yes. Okay. We always said you were in a rural location if you only had one fast food chain. Anyone else? Okay, so Erica, a community environment with limited access to resources and or services that urban counterparts have. Shannon, I love this. I also personally see it as the hometown place I grew up in. And yes, we still don't have a traffic light. I love it. When you get the traffic light, you know that you're moving towards city definition eventually. Okay, great. Thanks, guys. This is awesome. No fast food chains. Outside the big city. Okay, yep. So Margot says, beyond definitions, I think of ongoing lived experiences outside of the big city. Great. Okay. Thanks, guys. This is awesome. And I love asking this question. And I will ask this question in my classes that I teach as well. And I get so many different definitions. And surprisingly, or maybe not so surprisingly, a lot of what you guys have said as well. So, because a lot of our students here at UNBC, they come from what we would consider rural communities, right? So everything from Smithers, Mackenzie, you know, further up north, they're considered rural. Now, so remember I said that this was one of those things where this was a recruitment tool. It wasn't a research tool. So the first hurdle I actually had was determining, after med school, after residency, after these students had decided on where they were going to practice, I had to determine whether or not where they were practicing could be considered rural or urban. And originally, not having delved into this research that much before, I thought, oh, this will be easy. This, an afternoon, I'll code it all, not a problem. 2 months later, we finally had decided what was rural and what was urban. And the best thing we could actually come up with, because there isn't a standardized measure across Canada. So if you've done any of this, you'll know that Canada actually doesn't necessarily have a standardized measure of what's rural. Do you go with the government definition of rural? Do you go with more the economic definition of rural? Or do you go with the physician definition of rural? And Mal, what you posted was perfect, because that's one of the things that we look at is the practice subsidiary agreement of BC, which is the RSA. So BC itself has a specific definition of what rural is. So originally what had happened with this data that I received, and I received a data dump, and I had RSA numbers. And I went, great, what do these mean? What do these actually mean? I have no idea. So I had to go back and I looked, and I was like, why is this one town in BC, which I know is the same size as another town in Canada, why is one considered rural and one considered urban? So Prince George is a great example. In some cases, Prince George is actually considered rural. Whereas if any other place in Canada, you'd look at the size of Prince George, you would look at the population, we are urban. So it's really interesting. And that was the first thing we had to agree upon, was what are our definitions? So what I settled on is I did the RSA first. So I actually tried to compare it across Canada. So I took the information from the RSA and I went, can I apply this to the rest of Canada? Because obviously we have students who are practicing in other places in Canada, but they're not rural according to the Canadian definition. So I transferred it back. And then I realized that that doesn't always work. So I had to use the RST as well, which is the rural small town definition, which is a Canadian definition. So I actually took the BC data and I applied it to the RST. So it really is this interesting sort of conundrum when you're getting into this data and you're like, oh, this will be quite simple to do, quite, you know, run a few ANOVAs, I'll be good to go. Paul will be happy, Jeff will be happy, we'll all be happy. And then I go, oh boy, oh boy, oh boy, this is not working because of these definition problems. Okay, so from there, what I did is I took this data and I had put it into these definitions of RST, which is the rural small town definitions, and I gave them, assigned a number to them, and then I put it into categorical data so I could say what's rural and what's urban. Okay, and that helps me with my data analysis later on. This once again was a little bit of, you know, where do we draw that line? And we had a number of conversations around that, but we finally decided on what line we should draw. So next slide, please. So how many participants did I have? Originally in my data set, I had 130 students who had completed the program. And what I did is, if no recruitment data was available, so if we didn't actually know where that individual had ended up practicing, so whether it be they decided they didn't want to practice, whether it was they were doing more schooling, things like that, for some of these individuals, we didn't actually have that recruitment data. You know, I even did Google searches, things like that to see if I could find them, but that was a little iffy because I didn't want to assign something to someone that I didn't know for sure. So I felt comfortable with a sample of 97 students. So I lost almost a third of my group just because we didn't have that recruitment location at that time. Now, as I said, one of the things we were interested in was, did they go into family medicine or not? And what I found that about 62%, so I had an N of 60, decided to go into family medicine. Now, at this point, I hadn't determined whether it was rural or urban because I was going to leave that for later analysis. So 62% of my sample of 97 became family physicians, which is obviously really good. And you want that for obviously a medical school that is striving to have family physicians or GPs come out of their program. Next slide, please. So, sorry, it mixed up a bit. So what did I actually look at? What was my hypotheses? What were we trying to get? So first thing, the first big question for us was, if students from NP are they more likely to practice family medicine in a rural setting than in an urban setting? I was so happy when I found this out. The answer is yes. Okay, we found out that yes, according to what we had, the information that we have, those students that got into the NMP, they were more likely to practice in a rural setting. Now, how I did this is I just did a chi-square because we just had counts at this point, right? So we're like, how many people do we actually have, and how many people decided to do family medicine? So this was great. You know, we've answered this first question, yay. Now, the next big question, if you want to go to the next slide, Bree, was the big one. So, is there a relationship between the RRSS and recruitment location? This was a big one, right? Does this predict? Can we take our score from the RRSS and can we actually say with a certain amount of certainty that there's a relationship between the two? Now, if you notice, I haven't used the word predict yet, and I'll tell you why in a minute. So yes, we actually found, or I found, an interaction between the effects of recruitment location and practice type on rural experience. So those that had rural experience, okay, were more likely to go into a rural practice as opposed to an urban practice. Next slide, please. If it is. Okay, so why did I not say, can we predict? We can't predict yet. And I'll be perfectly honest with you, and this drives me nuts when statisticians are like, oh yeah, we can kind of predict it. I'm like, no, I showed a relationship between the two. And I may make that very, very clear here, is that I can't predict yet. Why can't I predict yet? Because I don't have enough numbers yet. So this is why we have more data. This is our next steps. And one of the really cool things is that if you remember, I said in the beginning, UBC is a distributed site. And other sites at UBC are using the RRSS to have rural seats. So what they're going to do is they're going to have more students fill this out. And for those of you that do research, obviously the larger your N, the better, especially when it comes to doing trend analysis. At that point, I didn't have enough. Is there a strong correlation? Yes, there is a strong correlation there, and there is that relationship between the RRSS, so this entrance exam, this entrance survey, and us knowing whether or not the program works or not. Questions? My last slide is just references, but I do know that it is the last HRI and people might have lots of questions or they want to have coffee. I don't know. I missed the coffee, I'll be honest.
Yeah, that's true. We did miss, we are all missing that.
Coffee and cookies.
Coffee, that's right. Well, thanks so much, Tammy. It's a really interesting and important glimpse into also just part of a obviously really important question for the research, health research community general in Northern BC. I do want to open up to questions. We've got the option of the chat function, so we'll keep an eye on that. Yep. I think we can also, if you want to put your hand up, we understand, oh no, we don't have the hand up function, do we? Been in so many different Zoom environments, I forget what we're capable of doing on which option. so for now, if we can put your questions in the chat box, and have also, I think one of the things that's really important or valuable about these sessions is that we can also just have some general discussion and input from other people that are working in similar areas. And obviously there's some people on the line who have had background experiences. I'm curious about anybody from the NMP, if you've got any observations, queries. We know this has been a topical question. What does I remember when these results, when did the findings sort of get released public, Tammy?
So they were presented at the Canadian Medical Conference in 2018, because 2019 we couldn't, everything was shut down. So they're just starting to trickle out, and we sort of did a preliminary analysis for that, and a lot of interest has been generated. So I'm actually currently working on pulling all the RRSS data, and we're going to make sure that it's coded. We actually did some inter-rater reliability coding just to make sure, being, the researcher I am, I wanted to make sure that it was being coded correctly, because you have people that are taking all these responses and they're applying numbers to them. So I wanted to make sure that we had that high level of intra-rater reliability, and we do for sure. So the training that you get, it's half hour, and we all actually had a high level of reliability, and there was about 5 of us from all different sort of parts of the university doing it. So yeah, that was really good. So I'm working on updating the data now. So especially that we have more of that recruitment data. I can't do in-person research, so I might as well do this type of research, because I can't do my pain stuff right now, unfortunately.
Yeah, and so that was one of my other kind of initial queries. We've got some popping up into the chat box now. One of the questions I had is, what is your sort of longitudinal sense with this work? And you started to touch on that now. So what is the sense of this? Is this going to be, are you planning for this to be an ongoing piece? You may have elaborated on this a little bit, but can you tell us a bit more about that?
You bet. So definitely this is a longitudinal study. So, I mean, every year we have students applying to med school. One of the first analyses I did on this data, and I was really quite frustrated because I had a ceiling effect right away, and I couldn't figure out why I had a ceiling effect. Why were NMP students scoring so high on the RRSS? Why couldn't I not find any differences? And I had one of those, kitchen moments where I'm baking and I'm like, duh, of course they're all going to have high scores. They all want to get into the NMP. They've listed that as their top school. So of course I'm going to have a ceiling effect. I'm not going to see any differences. So one of the things that I've actually proposed to the RRSS working group is maybe we could have other students fill this out as well. They sort of cringed at me and kind of said, no, we can't do that. And I said, oh, come on, we'd have so much data. And I kind of got shot down. But my hope is one day it can be part of the overall UBC package, because I think then we'll really see that difference, and we'll see, do we have that rural propensity? And what's really interesting, and this is purely anecdotal, so don't take this as written in stone or anything, is that I've had experiences with students who have come to NMP and they've transferred in from what I like to call the urban program from Vancouver, because they want to be a rural physician, but they've lived in a rural or an urban setting their whole life, and they're they go through and they become great rural doctors. So this is where it's really neat in science, where we can retest these theories and go, maybe it is something more than that. So I think there's definitely like a long-term plan here to actually learn more about these rural physicians and what makes a good rural physician. And in fact, Dr. Winwood and I were just starting research looking at what is a rural physician. And what I mean by that is what makes them tick. We don't know. There's all this research on when you become a rural physician, and then it seems to stop. Well, who becomes a good rural physician, right? So that's what that's our next step that we're launching into as well, in conjunction with the RRSS.
Cool. So we have got some questions coming up.
Yay.
It's great. And Mel's asked, has your team or another research team looked at the characteristics of medical students who went to the other 3 sites and who ended up in rural practice? So I think you were sort of starting to touch on this, but
yeah. So I'm hoping to, Mel, and that's why I've asked the team or the working group to consider perhaps having the RRSS as part of the application for med school to see what these other sites are like. I was really excited when they said that they were opening up a few more rural seats in those areas so that I can even look at those ones and just see, you know, is there a difference or not? Because in theory, it shouldn't matter which rural seat you have, whether it be here in Prince George, whether it be in Kelowna, you should be having that similar experience of having that rural exposure. So I'm hopeful that that will sort of come out as well.
Yeah, so we've said in the chat box there that if you'd like to turn on your mic, just let us know. Just send a note to the panelists and Bree can flick open your mic. But it is, there's a few different sort of nuances, and Mel, if you'd like to follow up with a verbal query, let us know. But Sarah asks, have you also looked at the location of residency training and final location of practice?
So that's
and is that on the cards?
Yeah, that definitely is in the card. So that is something that we're looking at originally, because we had sort of all these holes with the residencies. And obviously now that this has turned into research, not just looking at entrance scores and sort of an internal quality check, I'm going through all the ethics to make sure that I can actually follow up with these people as well. So that is one thing that, because UBC has been really great and they've given me anonymized data. So I don't know who's who. So there's that extra little step where I have to go back and go, somebody over there, can you find out where these people are? But that is something that we want to look at, is to see if residency location indicates whether or not you're going to stay there. And that's something I've had conversations with medical students previously where they say, well, I've done my residency here. I'm already established somewhat. I've been here for 2 years. I'm just going to stay here. Now, normally that's great if that residency is in a rural spot, but we don't have a lot of those spots. And so that's one of the things that I want to look at as well. Like, there's so much work here. It's amazing. It's like a gold mine, really.
Yeah, and you've introduced and said that your work is connected with others. You mentioned Paul Winwood and the team, but can you just sort of give us a little bit of context, Tammy, to sort of what's creating that foundation and collaboration for this ongoing work, and who the team is, and kind of how that's all sort of coming to bear? Because I think for this community, it's really important to know that this sort of longitudinal work's happening. If people are interested to get involved, where the connection, the touch points are, if people could imagine the possibility of connecting in or learning more about this sort of thing. So can you expand a little bit about the team and the future sort of possibilities? The future possibilities.
So most definitely. So it's actually one of those really interesting, serendipitous, sure, we'll call it that. When I graduated, so for those of you that don't know, I'm actually an alumni of UNBC. So I actually received my PhD. Yeah, sorry. And I'm like, most people know who I know, that's fine. So I actually graduated with my PhD in health psychology here. And actually at the ceremony, Paul Winwood happened to be one of the faculty on the stage. And afterwards he approached me and he said, I have some research that might be of interest to you. And I went, oh, wow, okay, right, I just graduated my PhD. I have, Paul Winwood coming up to me. I had a little moment. And he talked to me about this and he said, we have all this data, but not being statisticians, not having that rigorous background in research, we need help. And I said, yeah, sure, why not, right? What can it hurt? This is when I originally thought it would take like 2 months, get a quick paper out of it, woohoo, right? And then I realized that it was a little bit more complex than that. So, Paul brought me in and he said, I have this idea. And this is when we were talking about, who is the rural physician? And he said, but in the meantime, while we're getting all that going, can you look at this other data as well for me? And I said, sure, why not? Because the people that had been looking at it, they were either, going into graduate school, medical school, right? They didn't have somebody who could look at it full time. And so that's when, you know, I found out that Jeff had also been working on it as well, and he was one of the initial developers of this while he was at the NMP. So really, I mean, for me, I kind of fell into it, but it was near and dear to my heart because of the experiences I had had as a young girl, you know, seeing friends who were injured, having to wait for medical service, and knowing, you know, how quote unquote bad it can be if you don't have a doctor out there. And so this is where the interest really came in, and I went, can I do something? Can I actually help with this? And that's sort of where it came on. So it's myself, it is obviously Paul, he's you know, the lead of the team, and then there's some people from Vancouver as well who are part of it. So they actually have this working group, and Paul said, oh, you should be on this working group. And I said, okay. So, you know, I provide information. So we have information from other doctors and things like that. But really, when it comes to the data itself and the research part of it, I'm leading that with Paul, is really where it's coming from. I hope that answered your question in a long-winded way. So
yeah, no, it's a really, it seems like there's an exciting kind of ongoing body of work here. I'm actually just sort of putting a little shoulder tap out here that it'd be really interesting to see. One of the things that I've witnessed is that there are lots of other researchers doing sort of relevant and interrelated work.
Yeah.
You've focused on this particular data set and this ongoing longitudinal approach. But Neil, I don't mean to put you on the spot. You may be in the midst of other things or whatever. But I'm interested if Neil or other research, or Sarah, you know, where in terms of the practicalities of the NMP, you see this research kind of feeding in. I'd be really interested to hear from anybody that wanted to make a sort of a discussant type comment on this particular piece. Anybody willing to put their hand up? Attempting to make things interactive, which is very ambitious at the end of this time of year.
Zoom meeting number 4 probably for some of us today. Yeah.
Yeah, but they're probably even more for some of us. Thanks, Sarah. That'll be really great. We'll get Bree to promote you.
Yeah, there we go.
That power to a panelist.
Hi there. Can you hear me?
We can see your picture.
Yeah.
Oh, you can? Okay. Yes. I can't see
Yeah.
anybody, so I feel a little bit lost, but.
Oh, that's strange. Okay, but we can hear you and see your picture. So that's good.
Oh, that's better. Okay. How's that? Can you actually see me now?
There we go. Hey, Sarah.
That's better.
Hi.
Hi. And I can't, it's a funny format when you're a participant, when you're just a participant, because you can't actually see who else is on the meeting. So anyway, no, I was just going to comment. I think it's really important data to the NMP, actually, because I think the program for
I don't know if you can, I don't think I have the power to do that. We might need.
Oh, sorry, Shannon Freeman. I'm looking at here. I was looking at Shannon Wagner. Sorry. I thought I saw her name on there. Sorry. Maybe before.
Different Shannons.
She was on my previous meeting.
That's right. So just with the fact that we've got the recording restarted and where the conversation is just being acknowledged here, we had a really good question earlier from Kimberly Thomas around the need for attention to how inclusive rural sustainability scores are and if scores potentially affect recruitment of diverse students. And we had a really interesting section of discussion that wasn't recorded. So I just wanted to touch on that and push a little bit further, Tammy, that you've mentioned the Pathways program, and so you can't speak to all of the implications of your work or the ways it's going to influence things. But questions, you know, given that language of rural, remote, northern and indigenous often line up, can people in this context, can you give us a little bit of information about how at all the conversation of the selection criteria is tuning into dynamics for Indigenous communities as well as rural communities, and if that's part of the conversation in your considerations or not, based on the data that you've got.
Yeah, so I mean, in terms of who gets in, who doesn't get in, you know, the seats, especially things like that. I mean, that's not as much as what I know I look at with the RRSS, but I do know that there are, you know, we have had, and I believe we still do have, Indigenous students coming through the program, right? So that they can, and their whole thing is we want to go through the program so we can give back to our communities. And there's some really great examples. In fact, there's a few students that I know have been highlighted. I believe it was an Update, the UNBC magazine, a year or two ago. So, I mean, I think it's something that UNB or the Northern Medical Program, you know, UBC Med, it's something that they're aware of, right? We live in a diverse province, which is great. I love it. And it's understanding those things and ensuring that hopefully we can fill those holes. It takes time though. And this is one of the things that I think is so frustrating for people because, you know, I'll have people that'll comment to me and they'll say, well, we've been dealing with the shortage of physicians for such a long time. Why is it not working? Why, you know, are these holes still there? And the best I can say is it takes time, right? It's going to take time to get physicians in those positions and the changing landscape, because we do know, you know, with the economy in BC, communities, they get larger, they get smaller and things like that. So that's one of the things that I think we all need to be aware of. But Sarah, yes, you have your hand up.
I just wanted to comment specifically about Indigenous students because UBC has three you know, in addition or as part of its general admissions, it has three unique streams. One is the MD PhD, one is the rural stream. Oh, look, I have a little helper.
Awesome.
The rural stream, and the other is an Indigenous stream. So, and that's been in place for quite some time, led by James Andrews, and it very much targets the engagement of Indigenous students to the application of medicine and and supports their application into medicine. Indigenous students do not have to go through the Indigenous pathway, obviously, and they can also be considered in the rural stream and or MD PhD or general stream. So, but that's been in place at UBC, if I'm correct, prior to actually the rural admissions.
I believe so, yeah.
Well, that's really helpful. And I think there's always conversations to be had about the nuances of thinking about equity, diversity and inclusion aspects in northern contexts that I think we're all learning a lot about, and how proactive we need to be in the sense that if we're looking retrospectively to how things have been, particularly from lived experience, we may actually reproduce really problematic defaults going forward. So I'm glad that at least some of these ideas are on the radar as we're thinking about it, and something that we'll definitely need to be, we'll look forward to hearing updates on. I haven't seen any more questions. There's some thanks and contributions coming in. Great that we had at some point over 20 or so people here. Well, actually there's more, so up to sort of 30 or so as we were with our team. So any final thoughts from you, Tammy, as we put a wrap on today, or any final updates?
I just want to, I guess, say once again, thank you all for listening. I know it's December 10th and, you know, everybody's kind of burnt out already at this point with everything. And yeah, I look forward to maybe presenting next year and giving you an update, right, and seeing where we've come. Obviously, COVID is kind of putting a little bump into that, but, right, we still have data to look at. So yeah, I'd be excited to give you updates, and I'm always happy if people want to chat with me as well. You know, as I said at the beginning, I can only talk about it so much, especially with the specifics, but I am happy to chat with people because it is fascinating.
Yeah, really fascinating talk, and in that spirit, what I think is kind of cool is we've been running this seminar series now for several years. We're really prioritizing profiling UNBC health researchers, and we haven't even got through the new UNBC health research community yet. So cool. That's impressive. And Rachel, who knows, we're going to have access to a whole bunch of other researchers and innovations from different parts of our research community that we want to profile I'm happy to remind you, re-remind you, it was on an early slide, that on January 21, we're going to be hearing from a new faculty member, Kendra Ferber, and that's going to be our first one for the new year. By which stage, Rachel will already be off into her new role, as I understand it. So we'll be thinking about recruiting and identifying other, because I do actually think that some of the Indigenous researchers, and including organisations such as Carriacou County Family Services, is actually a next wave of work that'll be really good to recognise that there are, in our partner organisations, there's all of the Health Research Institute, there's all sorts of other approaches and leadership being shown in research, whether it's FNHA, Carriacou County Family Services, some of the exciting evaluative work coming out of Northern Health. So it's a pretty inspiring thing that for a university like ours, we've got such a diversity. So thanks everybody for being here, making the time for this conversation amidst everything else. Huge thanks to Tammy. And I think we'll have a two-part video probably for this session, but I'm glad that we could turn the recording on for that, for some of those important discussions about diversity and rural issues. Thanks for the questions, folks, and we'll sign off the recording. And a final thank you, Rachel Wells, we'll welcome you back at some other time. You're going to get shoulder tapped to be a presenter. That's what's going to happen.
I'll be here. Thank you, Tammy. Thank you, everybody.
Thanks, Tammy. Great talk.